So we look forward to having the keynote address being taken by Dr. Ramesh Kekunnaya, who needs no introduction in the field of pediatric ophthalmology or the ophthalmologists of the country at large. He's the network director of capacity building and also the director of the Child Sight Institute at LB Prasad, and is also a neuro-ophthalmologist. And he is going to be talking to us on progressive myopia and an overview of the current armamentarium. On to you, Dr. Ramesh.
Thank you, Dr. Chitra. Thank you so much for that kind introduction and having me in this webinar on myopia. So I'm going to summarize the overview, what is available at this point of time to treat this progressive myopic condition, which is we are restricting ourselves to only the progressive myopia, which is axial. The talk is mainly around that. So we all know that it's a global epidemic. It poses economic burden on most of the patients, which is lifelong, and also decreased quality of life for various reasons. There are many research initiatives to address myopia. Many people, many institutes, many societies are taking this up. And most important thing here is early intervention is the key. It's not that we catch the train at a later stage, but early catching is very important. And progression may be slowed or prevented to a meaningful or acceptable level. It's never going to be, 100% prevention. I would say meaningful and acceptable level so that you don't have a bigger or a severe complication of high myopia. That's the whole, purpose of this treatment of myopia progression. When you look at what are available, as Dr. Bhanumati said, lifestyle modification is the basic important thing. We need to start even before the child develops myopia. Even at a pre-myopic or hyperopic stage, you need to start, because this puts them at a different risk than the rest. Because if you start the child or a toddler or an infant with 3 or 4 hours of screen time, that child is going to have. Versus if the child has outdoor activities and everything from, early life, their chances are not never, but we can reduce this. Along with that, there are 16 to 18 permutations and combinations of treatment available for this arresting or stopping or delaying myopia progression in the form of, on the top you can see pharmacological or optical correction. And obviously it starts with spectacle or contact lens correction. And also there are orthokeratology, and combination of these are available. So the burden to this, I think, can be reduced by majoritarily by changing the lifestyle. That is the first part of any treatment for myopia progression. This is a base-up model. I have put it for you. Do a good refraction, torch-led examination, axial length evaluation, look at the retinal peripheral refraction, and also look at all patients with, rule out convergence, accommodative, or esophoria in all of these patients. As we discussed earlier, never underestimate the family history, because family history puts the patient into moderate risk, mild risk, and severe risk of progression. And also our good refraction, cycloplegic refraction, including central as well as peripheral refraction. And then you can suggest lifestyle changes. That's as a first base approach. Then spectacles, then optical treatment, the pharmacological treatment of eye drops of various diluted atropines, And then bifocal, whenever the patient has esophoria. Then there are optical modalities like DIMS lenses or Holt lenses. And then on the top, we have orthokeratology. And as I said, sun remains the very important factor. Sunlight, that's a very, very important factor of myopia uh, progression prevention. More and more evidence are coming even to light therapy. Probably one day I'll not be, surprised if there is a naturopathy for myopia in terms of various shades of light. And sometimes we need to give a combination of lenses, that is optical or pharmacological, or sometimes even contact lenses we might have to, the role of which is not very clear, but one must consider in this. So, in terms of evidence, more of this evidence are coming. But once there is evidence, how they practice depends upon, are you having this habit in the sense, if you are having a special profession, like if you are an ophthalmologist, you will go mostly into pharmacotherapy. If you are an optometrist, you will go into, you can just change the lenses to, Myovision or any kind of brand lenses, you can put it. And also availability and the affordability, because some of the countries, the low dose atropine is not available. In India, fortunately, 0.01% and 1% is available. At this point of time, 0.05% is not really available. But if you look east, in eastern countries, most of them are giving 0.05 because there is more and more evidence coming that 0.05% atropine works. Sometimes think, okay, for every patient, I'm going to give optical correction. So there are a lot of things, even if there is evidence, the actual practice becomes what you see in this slide. Just if you want to summarize, there are 7 points in the myopia progression control armamentarium. Number one, and the foremost, sometimes it looks very simple, identify a case of true axial myopia. As the discussion was going on, there are some patients, we don't know whether it's corneal or lenticular myopia. Where it works is where we have evidence is the true axial myopia. You do your, biometry, you do the cycloplegic refraction, you do a thorough slit lamp examination. You also look at, during biometry, look at the lens thickness. If it is too thick, like 4.2 or 4.3, you are looking at a case of microspherophakia. You're not looking at a axial myopia. If you are looking at, irregular astigmatism, you are looking at mostly a keratoconus. You are not looking at axial myopia. It may look very simple, but this is the most important factor. True axial myopia, which is not syndromic, that's a first step in identifying for the treatment armamentarium for myopia. Second thing is identify the risk factor for myopia progression. When you call progression, it's axial and progressing more than 0.1 millimeter per year, or refraction going more than 0.5 diopter per year. This is what are the risk factors for this, we need to see. And the third thing is whether there is parental myopia. When I say when both the parents are high myopic, for example, the father and mother are more than 6 diopters, then the child becomes a very high risk at the beginning. Even if the myopia is 0.5, I'll be a little bit aggressive in that particular child, versus both the parents are absolutely emmetropic. The child's refractive error is 0.5 or 0.75. I will always start with the, natural things like outdoor activities, less screen time and things like that. Versus if they have a high risk for progression, then immediately I will put them on some kind of optical or pharmacological treatment. Then, what is the near work the child is doing? Everybody asks for the near work, whether it is reading or screen time. One important thing I must tell that most of the kids, not all the kids, some of them read lying down. When they lie down and read, their distance becomes even more shorter. They have more risk. So I started asking the patient, are they lying down and reading, night reading? This is more risky than with the daytime or with a lot of light. If they read, it's different. Always try to do a relative peripheral refraction. If there is one, try to rule out. More and more cheaper options are coming to check the relative peripheral refraction. Use one of those, use them, and identify both central refraction as well as peripheral refraction. Always rule out lag of accommodation and esophoria by doing a cover test. The fourth step, this is the summary of my whole presentation. If there is pure axial without any relative peripheral hyperopia, you can start with low dose atropine. If there is relative peripheral hyperopia, defocus spectacles are probably better. If there is a lack of accommodation, as you can see in this slide, central distance EDOF design lenses or bifocals, PALS spectacles are better. If there is pure near esophoria on cover test, bifocals are better. Rest of the conditions, you can give orthokeratology up till -10 diopters. More than that, it becomes difficult. This is the recommended appropriate treatment of pharmacological, optical, or just a different lens design. These are the 4-5 simple things you can do in your practice. Out of the 7th, the 5th point is monitor the efficacy of your treatment. Either it is atropine or it is defocus spectacles or bifocals. You have to see what is good treatment, what is poor response, what is good response, what is poor response, and then look at what is to be continued. And it's not a 6 months course. You might have to continue it for 3 years, 4 years, sometimes even 5 years or 6 years. And the 6th point is you might have to think about combination. If one of them is giving a poor response.
1 minute left.
No, he's not. Vel Murugan, he's got 15 minutes. So I hope you're keeping track of that. On to you, Dr. Ramesh.
Yeah, I just have 2 more slides. That's it. So, and then when to taper also, we need to. More or less, I would say 2 to 3 years of stability. Up till around 13 or 14 or maybe 15 years, I would try to, stop this myopia treatment trial. And then this is a short summary we have made. Just a mnemonic is impact. Identify true axial myope, mark the risk factor, pick the progressive myope, appropriate myopia control strategy, and then consult and look at the response rate and combine other treatment modalities and monitor them regularly and taper before you completely stop the control strategy. This is the impact guidelines for myopia control using different things. And the last slide, this is by my colleague Pawan. Master, measure, monitor, and manage. Master means understand the multifactorial nature. That's why you need to do all these tests, customize your treatment for that particular myopia. Measure, estimate the possible myopia risk factors in that particular patient, whether there is esophoria, whether there is peripheral refraction, or is it true axial myopia. Then monitor closely every 3 to 6 monthly. I would say most of us practically do it every 6 monthly. And managed with appropriate anti-myopia strategy. Clear myopia management is beyond providing single vision correction. So this is the 4 M's you should remember in the myopia management. Thank you so much for this opportunity to provide an overview of what all are things available for treatment of myopia progression in children and even in adolescents. Thank you.
Thank you. Thank you, Dr. Ramesh. That was such a crisp, wonderful talk. Swati, do you have questions to take, or Dr. Rohit?
Yes, sir. Dr. Ramesh, I have a practical consideration. So when we go through most of the studies regarding these kind of myopia control glasses, they always exclude the children with intermittent or manifest squint. So when we have a child with intermittent exotropia, progressive myopia, we know that both of them are related. Have you personally dispensed glasses like this? What do you suggest we do? Does it worsen their control, the peripheral defocus? Do they start becoming more exotropic? Do we try the glasses and take them off?
Yeah, this is a everyday kind of situation where especially the strabismologists face. Most of them have mild to moderate myopia and they are in their 6 or 7 years of age. What I try to do is, if it is a very mild intermittent exotropia, for example, when I say mild, less than 15 or 20 prism diopters with the good control, I really don't change the anti-myopia strategy management. Really does not really matter. Either it is optical or, you are starting pharmacological. If it is beyond that with the worst control, probably what happens is if they have a optical correction, it'll come in their way, it might cost. So I tend to put them on only low dose atropine rather than anything else. Having said that, before that, I must clarify what is the ratio of, in my practice, what is optical treatment, what is pharmacological treatment. Having ruled out everything, still around 50 to 55% of the patients, we still give pharmacological treatment. With that, just 35 to 40, or in a given day, I might have given atropine for everybody also. So it varies. If it is moderate to severe, coming back to the question, moderate to severe, either intermittent exotropia or sometimes, strabismus associated with myopia can also have a esotropia. In this patient, especially in esotropia, I try to avoid atropine. I just try to see whether they have any amblyopia and everything. I correct that before really starting anything. Like if they have 35 prisms of esotropia, I would try to do some correction for that and then start this treatment. Intermittent exotropia, moderate to severe, I stick to pharmacological treatment for that. This is what I do. I would like to know anybody else differs or they have any other suggestions. Rohit or anybody, they can comment.
So I think broadly, this is what we follow. It's just that I would always be far more sensitive for any other problem and managing that if I have a management for that before I'm, kind of thinking, contemplating and deciding on myopia, because myopia is a chronic problem. So I'm looking at an intervention depending upon the age of presentation from somewhere anywhere from 4 to 10 years, depending upon when the child is presenting to me. Whereas if we are dealing with, say, amblyopia, that's a treatment modality which I'm looking at intervention from 6 to 8 months. So that takes absolute priority. I would not, kind of blindside the parents about myopia and everything like that. I would really insist on amblyopia therapy, and that's something we must remember. The parents should not be confused with a whole lot of interventions. The most important thing is vision. The eye needs to be able to see, and amblyopia therapy. Esotropia, again, manage whatever way it is. If it's accommodative management, or if it's surgical, early surgical intervention, and then think of. In intermittent divergent squint, there is a wee bit of challenge, as Ramesh said, that there is a bit of a challenge in our deciding on that. Again, just because by the sheet anchor of the interventions that we have done, predominantly for us also more than 2/3 even now interventions are are pharmacological as compared to optical. And I have a lower sensitivity towards, operating intermittent divergent squints who have progressive myopia, because, like I said, I want to get over with that much faster than rather than start talking to them about near exercises, fusional versions exercises, and increased near work, which actually is counterproductive when I'm talking about their, myopia management. So I'm a little more sensitive towards interventions in intermittent divergent squint with progressive myopia. And I would still, as Ramesh said, would prefer pharmacological interventions to them if I am intervening as compared to an optical intervention.
Thank you. Thank you, Dr. Ramesh. Thank you, Dr. Rohit.